Let's move on to Industry Symposium Sanofi. Let's get real, minimizing allograft rejection in kidney transplantation, applying the evidence to real-world scenario. May I invite the speaker, Dr. Daniel C. Brennan. May I also invite Dr. Dinesh Kullar to moderate the session. And the panelists for the session, Dr. A.B. Abraham M., Dr. Shishir Gang, and Dr. Vivek Pathak. Over to you.
Well, good afternoon to everyone here in India, and good morning to Dr. Brennan. So let me first express my deep gratitude to the organizing committee for this wonderful opportunity. Well, it's a matter of great honor, just not because of the fact that the famous and hugely popular transplant physician of the world, that's Dr. Brennan, is going to address us one more time, but all the more because of the fact that one of the world's best known transplant physicians is going to address us when the local time at Baltimore is 4 o'clock in the morning. That amply highlights the fact as to how strong a bond he has with all of us here in India, the nephrologists, the transplant surgeons, and the transplant physicians. And he's ever willing to help further the cause of renal transplantation, ever willing to help all his dear friends, and I'm proud to be one of them. Well, let me assure you, Dr. Brennan, that we in India truly acknowledge those sentiments. And you, as a result, command huge respect and a tremendous gratitude from all of us who are associated with the field of nephrology and kidney transplantation. And that's the reason why you are truly adored by all of us here in India. And I think a mere thanks is not going to suffice, but I hope you understand the sentiments. And I represent the large community, that's the Indian nephrologists, transplant surgeons, and physicians. And more importantly today, the members of Indian Society of Transplantation. And we are eagerly waiting to hear from you and then be able to interact. And I have the pleasant task of moderating the session, and I'll be joined by one of the few of the country's best known nephrologists who will be flanking to spearhead the discussion with you. Over to you, Dr. Brennan.
So
thank you to the organizers and to Sanofi for inviting me to speak today on minimizing allograft rejection in renal transplantation. I'm Dan Brennan. I'm the medical director of the Comprehensive Transplant Center and a professor of medicine at Johns Hopkins in Baltimore, Maryland. This is a list of my potential conflict of interests. Historically, rejection has been classified according to the type, the onset, the mechanism, the treatment, and the response to the treatment. Hyperacute rejection would occur in minutes to hours, and although rare, is felt to result from preformed antibodies, and our screening now prevents most of that. There's really no treatment, and graft loss was inevitable. Accelerated acute rejection occurred in hours to days, and resulted from the activation of pre-sensitized T cells. Reversal could occur, but there is usually impaired renal function and a shortened survival. Acute cellular rejection could occur in days to weeks. Without antibody induction therapy, it was more on the order of days, and it resulted from activation of pre-sensitized T cells. Mild acute cellular rejection was reversible with steroids in 70% of cases, and moderate to severe cases required use of lymphocyte depleting therapy with anti-thymocyte globulin, ATG, thymoglobulin, or OKT3, which is no longer available. Acute humular, or what used to be called vascular rejection, because it caused injury to the vascular area, occurred in days to weeks, and not only was it from activation of pre-sensitized T cells, but now B cells as well. Interestingly, steroids seemed to be helpful in 50% of the cases, but ATG was required in most of the cases, but it still had a response rate, especially when it was early, and we'll return to that, of 75 to 90%. Chronic rejection is a term that is no longer used, but we kind of understand what it is. So chronic rejection was felt to take place over months to years, and there was both immunologic and non-immunologic causes, and therefore the term rejection was no longer really favored. So terms like chronic allograft nephropathy, chronic renal allograft dysfunction were used to get rid of the emphasis on the immunologic part or the rejection. But then people were worried about the chronic because it could occur actually pretty early. And so you get your double contours in your kidney within the first month. So is that really chronic? At any rate, it seemed to be slowly progressive. What's important is when you institute a therapy, if you don't really see a change in about 5 days, it probably isn't working, and you need to consider other treatments, such as things we did in the olden days, like irradiation of the graft, splenectomy, or use of cytotoxic agents like cyclophosphamide. The Banff workshop codified our approach to rejection by giving descriptions of it and gradings according to the glomeruli, the tubules, the interstitium, etc. It changes over time, which is good because it's a working, living document. But it changes over time, which is bad because it keeps changing and the definitions change. So it used to be for antibody-mediated rejection that you expected there to be graft injury with an elevated creatinine. You expected there to be C4D on the histology, and you expected there to be DSA. But that has changed. And the most complete Banff criteria is from 2017 with modifications since then. We are due for another update. The Transplant Society, TTS, convened a number of experts to discuss antibody-mediated rejection and other things. We're going to focus on antibody-mediated rejection, and their findings were published by Kerry Shintak in Transplantation in 2020. What they concluded was that antibody-mediated rejection can, first of all, be broken down into what is called active or chronic active. Kind of confusing terms. They said for active antibody-mediated rejection, you still needed 3 criteria. Histologic evidence of acute tissue injury, with one of the findings below, A, B, C, and D, microvascular inflammation, intimal or transmural arteritis, acute thrombotic microangiopathy, or acute tubular injury, ATN. Wow. So that was in some of the earlier versions as well. ATN could be antibody-mediated rejection. That's still hard for me to quite understand. 2, evidence of current recent antibody interaction with the vascular endothelium. That could be linear C4D. It's great when you see it. At least moderate microvascular inflammation, so either glomerulitis, the G, or the PTC, the peritubular capillaritis, or here's something new, increased expression of molecular gene transcripts or classifiers that have been associated with antibody-mediated rejection. Parentheses, comma, if thoroughly validated. And then serologic evidence of, changing, not only DSA, but it could be other antigens. So maybe angiotensin 2, et cetera, or many non-HLA antigens. It's felt now that 50% of antibody-mediated rejection is from non-HLA antibodies. It's just, what are they and what do you do about it? Chronic active requires evidence of chronic tissue injury. So things like transplant glomeruli with splitting of the basement membranes or arterial intimal fibrosis of new onset. So the antibody-mediated rejection can be broken into phenotypes characterized by when they occur, just like it used to be historically. There could be early acute, less than 30 days, or late, greater than 30 days after transplant. Early acute is felt to result from pre-existing donor-specific antibodies. You see the histology criteria, as we just went over per Banff, and then the clinical presentation tends to be abrupt. So it's not a creatinine creep. It's felt to be from a memory B-cell response, and the graft will be lost within days, if not treated. So how often do we see that? Not very often, really. But when we do see it, we try and treat it. There are certain factors that make us likely to see it. For instance, doing an HLA incompatible transplant when the T-cell cross-match is positive by AHG, anti-human globulin, CDC, complement-dependent cytotoxicity, or high-flow cytometric cross-match. For the late antibody-mediated rejection, there can be pre-existing DSA like in the early. Again, this is a little confusing. It can be active or chronic active. There can be allograft dysfunction or not. Whoa. Proteinuria or not. It's felt to be a pre-existing plasma cell response, not B cell. We don't have very good drugs against plasma cell. And graft loss now occurs with months to years. Or you can have de novo DSA. And actually, people, de novo DSA turns out to be worse than having pre-existing DSA. The histology is as I just described, the Banff 27 criteria. And now you can have a mixed rejection with a T-cell mediated rejection on top of your antibody-mediated rejection. But again, confusingly, there could or could not be allograft dysfunction, could or could not be proteinuria. It's felt to result from an underimmune suppression. That underimmune suppression is usually a lack of the inadequate calcineurin or tacrolimus levels, as MMF doesn't seem to control DSA after about 3 to 6 months. If you look at the histologic criteria, it's as we just described, the clinical criteria as we just described, and the DSA characteristics a little bit different now. Some people look at C1q positivity. I think most people now feel that that's not necessary if you have a high MFI. The question of the MFI is problematic, though, because the Luminex assay says positive is greater than 500. But most people use a cutoff of 2,000. But all MFIs are not created equal. Some FIs of 10,000 don't cause any problem at all. And some of 1,000 are very problematic. So the therapies that we usually use are plasma exchange and intravenous immunoglobulins. They looked at this in the TTS document. There's a biological rationale because the HLA antibodies can be removed. You can use intravenous immunoglobulin, which has a whole bunch of pleiotropic effects, neutralizes antibodies, cytokines, cellular components, non-cellular components, and these are the two references. Note they're quite old. And then, is there a benefit in clinical observations? Well, people have used pheresis and IVIG and said, some very old papers have said, yes, maybe it helps with renal function. Most of us have used this, and early on, I think we've seen it work, but later on, it just doesn't seem to work. And then there are the international recommendations from the FDA workshop that was in 2017, and then the KDIGO, the Kidney Dialysis Improving Global Outcomes, 210 recommendations. Again, kind of old documents. And then what is mostly used in clinical practice. So there is American Society of Transplantation survey. I don't particularly like surveys. So you ask people what they do, it doesn't say that it works or that there's any real reason to do it. And as you can see, what happens is they came up with consensus guidelines. So for the early acute, just as we talked about pheresis, IVIG, a little bit IVIG after each pheresis to block the FC receptors, and then corticosteroids. Interestingly, corticosteroids, which we all use for this, are only an expert opinion, okay? There's no evidence. So what about adjunctive therapies? Well, complement inhibitors, rituximab, splenectomy, they have 2B and 2C recommendations. So they're hardly a recommendation at all. What about late antibody? Well, you see the same thing. There's basically very poor evidence that anything that we do is actually effective and works, and is expensive, and sets people up for infection and malignancy. There's a paper a long time ago by John Persh from the University of Wisconsin. I cite it in here, but this also is from up to date, and it says what we do for steroid-resistant rejection, antibody-mediated, and mixed rejection. The interesting thing to me is, I said before, with vascular rejection, steroids were effective, and we don't really think about that. But this paper from Wisconsin showed that steroids can also be used for steroid-resistant rejection. You just need to use a lot of them. Lymphocyte depleting agents can be used, either rapid ATG now, thymoglobulin, and a dose of 3 to 10 milligrams. Why only 3? Well, what if you got induction with 6 or 7 milligrams per kilogram? Well, there's evidence that if you exceed 10 milligrams per kilogram, certainly over a year, maybe over a short several years, that increases your risk for PTLD. Then there's alemtuzumab or Campath. People like this because it's one shot and peripheral and it's done. There's been some efficacy of changing from cyclosporin to tacrolimus, azathioprine to mycophenolate, and then IVIG, pheresis, rituximab, bortezomib, and eculizumab, as we talked about. With all that, the Transplant Society, in this 2020 document, came to the conclusion that while it was agreed that the aims of treatment are to preserve renal function, reduce histologic injury, and reduce the titer of donor-specific antibody, the titer, not get rid of it, there is no conclusive evidence to support any specific therapy. As a result, the treatment recommendations are largely based on expert opinion. They said, it is acknowledged that properly conducted and powered clinical trials of biologically plausible agents are urgently needed to improve patient outcomes. I'll return to that towards the end of the talk about some potential new agents that are in development for treatment and prevention of antibody-mediated rejection. But let's look at the incidence of antibody-mediated rejection. How prevalent is it? And what's the outcome? So in a paper by Badagarandi, published in American Journal in 2015, he looked at deceased donor-compatible transplants, and the overall rate of antibody-mediated rejection was only 1.7%. Wow, that's low. Subclinical rejection was only 0.1%. In deceased donor HLA compatible, overall rejection was 44.7%, with 16.5% being subclinical. And live donor compatible was very low, 0.7%. Live donor incompatible was higher, but much less than HLA incompatible. And we're going to return to that HLA incompatible desensitization group in just a little bit. Live donor HLA incompatible was similar to deceased donor, with a 47.4% acute rejection rate. You know, in the United States right now that the rejection rate is running overall between 5 and 10% in 1 year. So in another paper, Dr. Arandi looked at the outcomes. He got data from a bunch of transplant centers in the United States that were doing desensitization in various varieties of IVIG, pheresis, and IVIG, etc. And he looked at the different types of desensitization or degree of incompatibility that you had. On the left, it shows the percent graft loss, which, if I remember correctly, is death censored, okay? On the top line, in the orange dashed line, is the percent graft loss over time for those with a PCC, a positive cytotoxicity crossmatch. You can see that these are living donors, and by 5 years, it's 40%. If you look on the right and look at the mortality, remember these are living donors, by 5 years, it's almost 20%. So I have this right. This is a 60% graft loss of a living donor in 5 years. The half-life of a living donor kidney transplant right now in the United States is about 19 years. The half-life, if you do a positive cytotoxicity crossmatch with the best desensitization you can throw at it, is about 3 years. Not very good. What if you did a positive flow, but a negative cytotoxicity match? Well, that's the green dots. And you can see that graft loss is still almost 30% by 5 years, and death is about 12.5%. Death. These people died. Okay? Then if you look at a positive Luminex but a negative flow, well, that's not much worse than doing a compatible transplant. So that's important. If you just have a DSA positive, one, you don't die, and two, from the therapy you did for desensitization, because you don't need much. And then the other is, you don't have much in the way of rejection, although it is up to 20% by 5 years. But you look at 1 year, it's down in the same level as the compatible, which is what the US is getting, about 5% per year. So to me, antibody-mediated rejection right now is an elusive clinical conundrum. We don't know how to define it because we can't really tell what is acute versus chronic. This inactive versus active is really poorly defined. We don't know how to diagnose it because we don't diagnose it histologically, serologically, molecularly. And then we have this entity of C4D negative, DSA negative, antibody mediated rejection that might not have any histologic changes besides ATN. That's hard to make a diagnosis. And if you can't make a diagnosis, it's hard to treat. So is it any wonder that our therapies, plasmapheresis, IVIG, rituximab, proteasome inhibitors, don't work? Some of the new things, anti-IL-6 antibodies, JAK3 antibodies, inhibitors, we have too little data to know, but I'll talk about that at the end, about some of the future therapies that we might use. The other problem is, how do you know when you're having a antibody-mediated rejection, as I just said? And part of the problem is that DSA, which we think, oh, DSA, well, Terasaki showed years ago that 50% of DSA have no clinical impact. And that's been shown in over and over. And this is a recent paper that Stan Jordan looked at the role of cell-free DNA to try and discriminate what I would say harmful from non-harmful DSA. On the far left, you have the large box and whiskers with those who are in red, DSA positive, and had an antibody-mediated rejection. The median cell-free DNA, donor-derived cell-free DNA, was 2.9%. At the time he did this study, 1% was felt to be the threshold for positivity. Now people are considering a threshold of 0.5 or 0.7% to increase the sensitivity and capture T-cell mediated rejection 1A and even borderline. But there are 16 people who fit that category. There are 17 people who are DSA positive with no antibody-mediated rejection. Okay? 16 versus 17. Just what I said. 50% of those with DSA do not have antibody-mediated rejection, and their cell-free DNA is low, less than 1%, for the most part. There's a few outliers, like this person up here. It's not a perfect test, or there's something else going on, BK, something that is an antibody-mediated rejection. And then he found out that the majority of these people were DSA negative, 57% of 57 of them. They're predictors of the outcomes in antibody-mediated rejection. The timing, as I told you early, we see that, and you know that by experience. Occurs in the first week, 2 weeks, maybe the first month. You see the creatinine rising up rapidly. Everything fits. The histology fits. The DSA fits. There's C4D. You pherese them. You give them IVIG, maybe rituximab. A lot of those people get better. What about the donor-specific antibodies? Well, the problem is, I just told you 50% don't matter at all. And then there's the strength. Well, I just mentioned that the MFI doesn't really matter. Low MFI can be very harmful. There's a DSA subtype. We don't make enough about this. What are the antibodies to? Well, it is known that if they're to class 1, that's probably not as impactful as if they're to class 2. And then what about their complement binding capacity? Well, we don't usually measure that unless we do the C1q assay, which most people don't do. We looked at the graph function, and here at the bottom is one of the biggest things. This is actually one of the things that's inexpensive and we can do, and that is increase adherence. We are fortunate in the United States that last year, President Donald Trump signed into law that Medicare would pay for immunosuppression for the lifetime of the patient. That's amazing. It will go into effect into 2022. So we're looking forward to that to at least remove the financial barriers to adherence. But they're not all financial because rejection still occurs in our system at the veterans hospitals where everyone gets their medicines paid for. A recent study, the MAGIC study, looked at an intervention to improve adherence. The MAGIC study is a medication adherence given individual system change. It was a randomized controlled trial to test a 6-month intervention designed to enhance medication adherence in adult non-adherent kidney transplant recipients. So they took, as those that they enrolled, people who were already identified as non-adherent and randomized them to the intervention or to just more attentive care. So with the adherence, with the intervention, they linked adherence to established daily routines with environmental cues and supportive people. What did that include? It includes setting cell phone alarms for your medicines, placing medicines next to objects in the environment of daily routines, such as close to the coffee pot, the television remote control, your toothbrush, or car keys. I've had to take medicines, and I can tell you that for me, what works is having them once a day in the morning when I wake up. That's the only way I can be very adherent, because I miss a noon dose almost all the time, and the evening is hard as well. So it also involved other people who will help you, people helping people. But ultimately, they showed that the best adherence was when the medications were placed in the right place at the right time. For me, I told you, that's in the morning, in the bathroom, in the medicine cabinet. At 6 months, the median medicine adherence score of the intervention group was 0.91. Remember, these people were 100% non-adherent. So it had improved to 9%, such that only 9% were still non-adherent. In the attention control group, it was 0.67. So that's still better than average, but not anywhere as good as when you had an active intervention. And these are simple things that you can do for your patient. I told you I'd talk a little bit about the future of desensitization and how we might prevent rejection, and especially antibody-mediated rejection. This is from a review by Kwan and Stuart Konecki, and it shows in the top a germinal center in pale green with the CD4 positive T cell presenting antigen in the complex of the MHC right here in the middle with co-stimulatory molecules to a B cell. Then there are other B cell signals in 2 that lead to other mediator signals in 3 that lead to the plasma cell activation and release of antibodies. And then the antibodies off here, the antibodies in 5 go off to bind to complement or to the C1q complex, which is bound to the graft and can lead to granzyme and perforin and complement-mediated cytotoxicity. Going back to 1, we have a various co-stimulation molecules: anti-CD28, anti-CD40, CTLA4, anti-CD154. What's important is you might have heard that the anti-CD40 monoclonal antibody that was in development just in the last few weeks was shown to be less effective than tacrolimus, and so that it's not being developed further. We know abatacept has been used. That's Orencia in the United States for rheumatoid arthritis, and some programs use belatacept, but the original data showed there was an excessively high rejection rate, and so the programs, such as Emory in the United States, are now using a quadruple therapy with induction, belatacept, tacrolimus, MMF, and prednisone for the first year, and then weaning off the tacrolimus and keeping low-dose prednisone. B-cell antibodies, we've talked about rituximab. There are second-generation anti-CD20s, anti-CD22, anti-CD52 is CAMPATH. Mediators, anti-BAFF, you know about that because those are being used now in lupus, maybe with some efficacy. That's a little debatable. Plasma cells, I didn't talk about those much. There's first-generation bortezomib, then second-generation carfilizumab and ixazomib. There's a new drug, the anti-CD28 monoclonal antibody, daratumumab. We'll see what happens with that. I think that animal models have looked good. Alloantibodies to the anti-FC receptor, and then the New England Journal paper now several years ago looked at IDUS, the strep pyogenes enzyme that cleaves antibodies, and within minutes to hours completely eliminated any anti-HLA antibodies, but there was a rebound. People are looking at C1 esterase inhibitors, anti-CD3 or anti-complement 3 and anti-complement 5 monoclonal antibodies as well. This has all been a little bit of a downer, but I want to end this on a positive note. You keep hearing that, oh, we have made great improvements in rejection. They've gone to 50% to 10% a year, but we've had no improvement in the half-lives. That simply isn't true. And together with Emilio Poggio, Jesse Scholl, others, we published the results in recent times. And you can see in the top, looking at graft survival of deceased donors, and the bottom looking at the half-lives of live donors. And you can see that the graft survival over time has improved from 8.5 years not too long ago, 1995 to 1999, okay, 20 years ago, to now 11.7 years. That's a 50%, almost a 50% improvement. And in living donor transplants, it's gone from 12 years to 19.2 years. So people, we are doing well. Can we improve? Of course we can, but we're doing pretty good now. So in conclusion, we have done a pretty good job with thiamoglobulin, tacrolimus, mycophenolate mofetil, and prednisone. Half-lives have improved for both deceased donor kidney transplants and for living donor kidney transplants. Rejections are not the same as they used to be, when they used to be primarily T-cell mediated and easily reversed with steroids. Now they're more complex. Desensitization, unfortunately, is not what we thought it could be. We can do better, but we need better tools to recognize, prevent, and treat non-adherence, and we need better ways to manage incompatibility. Living donor, paired kidney exchange, and if needed, right now, as a last resort, desensitization. Thank you for your attention.
Thank you very much, Dr. Brennan, as mesmerizing as ever. So, ladies and gentlemen, let us now welcome Dr. Brennan live now. And please let me remind you, it's 4:30, around 4:30 in the morning at Baltimore at the moment. So our sincere thanks, Dr. Brennan, to be a part of our meetings yet one more time. So before I involve my fellow panelists, my dear friends, let me ask you a few key points which actually arise out of your talk today. And one, of course, something which you highlighted, and I know you have your own work as far as the donor-derived cell-free DNA is concerned. We would like to hear more from you, because you see, we know that by the time rejection actually happens and it translates into an elevated serum creatinine, it's too late. So we are excited because the test known as AlloSure in your country is available as AlloSeq in our country, recently been introduced. So we would need your inputs as far as that is concerned. Would you be more concerned about the negative predictive value, as you said, or are you excited about the positive predictive value as well?
So thanks, Dr. Kular, and thank you, everyone. As you know, I love India. I wish I were there. I wish we'd all could be, but it looks like you're all at home or in your offices as well. So someday we'll get control of this beast and we'll be able to get together and see each other in 3 dimensions. So the donor-derived cell-free DNA, I am excited about it. I'm excited about it in the way that I have approached many of my successes. So I didn't think thiamoglobulin would do much. I didn't think that ganciclovir would do much, and they turned out I was wrong. Well, similarly, I didn't think there would be much of a role for donor-derived cell-free DNA. I think the negative predictive value is pretty fantastic, and clearly there's a utility for using the donor-derived cell-free DNA as a for-cause test. So to avoid biopsies. Biopsies are problematic. They're expensive, people can bleed. So if we have a non-invasive way to prevent the need for a biopsy, I think that's useful. I think there's really pretty good evidence for it used that way. That being said, it's a biomarker. It's not a perfect test. For instance, with troponin, we always look at troponin and think, oh, it's elevated, but talk to your cardiologist. How many times, oh, that's not an MI, that's a troponin leak, or that's not a troponin leak, that's an MI. So again, it's a biomarker. Nothing's perfect. And also it looks at injury, not just rejection. So you have to realize that injury from BK, injury from urinary tract infection, sepsis. So I don't think there's great evidence, although there's just recently published evidence looking at I think it was published. It was certainly presented at the ATC in the Admiral study. So that is based on the KOCHI study, which is the Kidney Outcomes AlloSure Registry. So it's a registry study, not a prospective study, looking at serial monitoring. That was part of the original DART, which there were 2 parts of the DART study, looking at the for cause and then looking at the monitoring. So it looks like it's useful. And where I take a little bit of satisfaction or hope is that it's been useful in lung transplant, very useful. There's a doctor, Sean Agbor-Eno. He's actually mostly at the NIH, but a little at Hopkins. He's a transplant pulmonologist. And he has shown clearly that the donor-derived cell-free DNA goes up before there is rejection by about 3 to 6 months. He designed a trial that has just started, and now he's changing it already because the trial was designed to, once the cell-free DNA started going up, he randomized them to plasmapheresis IVIG, rituximab versus continuous monitoring. He's thinking he needs to change that already because he's got something through the NIH, a different drug that blocks a different signaling pathway. So I like it because it isn't just for kidney. We're seeing the same kind of biologic phenomena in other organ transplants, like lung transplant. I think it's really useful, Dr. Kular and everyone, in lung transplant, in heart transplant, because they don't have a creatinine to follow. I mean, creatinine is not great, but it's non-invasive. They have to do bronchs and they have to do cardiac catheterizations. So I think in both those situations, they've paired that as well with gene expression profiling, which people are talking about. And for the heart transplant, there's the AlloMap. And now there's the AlloMap for kidney that's being researched. And there's just a publication that just last week that just came out in kidney transplant, looking at a 5 gene expression panel. So I've been talking away here. I think there's something to this. In America, it's really expensive, not crazy about that. So, and I think you know me, I'm kind of a less is more person. So do we need all this monitoring? Do we need to check DSA? I don't think we need to check DSA. And think about antibody-mediated rejection. As I showed you, in compatible transplants, it's less than 5%. So if you monitor everyone, that's 95% of the people you're monitoring for no reason. So that's the next thing. Who do we monitor? How do we monitor the right people? Okay, I'm done.
That brings us to something equally important, and you highlighted the importance of that, and that's the compliance. So you had showed the via MAGIC trial the importance of compliance. Would you be interested in advocating the cause of once daily tacrolimus to enhance the compliance?
Yeah, I like the once daily tacrolimus, and was part of the kind of excuse me, the early Envarsus trials. That's what it's called in the U.S., the extended release. So Astagraph, or whatever it's called in India, Europe, it's not exactly an extended release. But tacrolimus has a pharmacokinetic profile that's very similar to the immediate release. So it caught on in Europe, it never caught on in the US because you still had the same side effects: insomnia, tremors, etc., alopecia. So with the Envarsus, there's definitely less tremors. That I think, in my experience, less insomnia. If you look at all the literature regarding adherence, once a day medicine work better than twice a day, work better than 3 times a day, work better than 4 times a day. So I like it. It can be expensive in the United States, but I do like it.
So we now moving on to the treatment bit. One difficult kind of rejection which we all encounter is when there has been non-compliance and we come across a plasma-rich cell acute rejection. How would you recommend treatment of plasma cell-rich acute rejection?
Well, first of all, I'll make a recommendation but I don't know is the real answer. So plasma cell rejections are difficult to treat. So I hope I showed that schematic of the future of transplant in part to try and understand, as we understand immunologically and mechanistically, where we might intervene. So intervening early before the plasma cell gets developed is probably the best way. And the best things that we have to do that, of course, are depleting T and B cells, because remember, T cells give B cell help and B cells become plasma cells. So to me, I think there's a role for lymphocyte depleting therapy I think thymoglobulin is safer. I think Gampath is easier to use because it's
no role of bortezomib because you said you're
I
not
don't
excited.
think so. So I don't think so. I was just talking to my fellows about this too, and they asked me, "What about bortezomib?" And I just laughed. And what I said to people is, it's not that I haven't tried it. I've tried everything there is, and that's one that just didn't work. I have a paper in clinical transplantation where we had a patient with multiple myeloma, and so we were giving the patient bortezomib. So for some reason, I think it was because we were thinking about a next transplant and with a brother or a relative who was ABO incompatible, I looked at his isogluten titers, and there was no effect of bortezomib. And so we know that controlling isogluten titers in ABO incompatible transplant is relatively easy compared to controlling anti-HLA antibodies. So I took it's a leap, but I said, if you can't control the anti-ABO, the isogluten titers, you're probably not going to be able to control the donor-specific antibodies. And essentially that's true. If you read Steve Woodall's stuff, I mean, they throw everything at the same time. So it's hard to sort out if anything is working, what is working.
So let's switch gears now and bring on board my friends from India. Is Dr. A.B. Abraham the organizing chairman? Has he logged in?
Yes,
We can't see.
Dinesh.
Okay. Yeah. Okay, great. So, RTS, congratulations, Abhi. First of all, a fantastic kickstart to the conference, and our best wishes for the remaining part. So, my question to you now, let's hear and get to know the Indian perspective. So, what typically goes on your mind when you are thinking about the pre and post transplant risk factors for acute rejection, Abhi? That, of course, will finally help the probability of or mitigating the probability of immunological graft damage. So the risk factors which you have in mind while going ahead with the transplantation, because the topic today actually is minimizing the risk of acute rejection, and we'll go back to Dr. Brennan talking about a few of those things again. Abhi, over to you.
Thank you, Dr. Brennan, for the wonderful talk. And I represent the organizing committee. It would have been a pleasure to host you in Kochi. Maybe next sometime in future we'll be able to do that. And as far as the risk factors for rejections are concerned, I would say like an increased number of HLA mismatches, then DSA strength. Although there is no clear-cut guideline available about this, higher the DSA strength, higher the risk of rejection. For example, somebody has a DSA of 6,000 plus, has a higher risk of developing rejection as compared to those who has a DSA titer of 1,000. Then the class of antibody, we don't check whether they bind C1q or not. Then increasing donor age is also associated with increasing rejection. If the donor is more than the age of more than 60, the higher the risk of rejection. And then I would say delayed graft function, like if the kidney does not function immediately, that is also associated with increased risk of rejection. Then I would say like
So
these are increased.
what do you really do when you come across these kind of risk factors? So how do you tailor make your immunosuppression, and what kind of TAC levels are you targeting in these kind of patients vis-a-vis the people with lesser risk?
Yeah, those with increased number of HLA mismatches, we go for, in fact, for all our patients, we use induction immunosuppression, either thymoglobulin or basiliximab. So those with increased number of HLA mismatches and those who have higher DSA titers, we go for thymoglobulin. And we also go for desensitization therapy for those who are particularly a DSA titer of more than 2,000. And what we do is actually we do several sessions of plasmapheresis, which is also associated with we give about 5 grams of IVIG post session, and at the end of it we give a loading dose also. It's about 1 to 2 gram per kg. That's a total dose of IVIG we give as part of desensitization protocol. And
So the
we,
question is, I'm sorry to interrupt, so I'll get back to you again. So this is a very important thing which you touched upon. Dr. Brennan, your comments on if you have a CDC crossmatch negative, you have a flow cytometric crossmatch negative, yet the MFI could be something like 2500. But would you believe that they are not C1q binding? Maybe the MFI is not relevant. Would you go ahead without desensitization, or would you also want to desensitize?
So it depends. So what we will usually do is list those people for try and get them involved in the paired kidney exchange for several months. And if nothing happens after several months, we would probably go ahead. One comment regarding the use of the IVIGG, something that one of my nurse practitioners taught me after I hired her. She said, you know that each unit of fresh frozen plasma contains about 5 grams of IVIGG, and that if you give the IVIGG, there is less bleeding, or the fresh frozen plasma, there's less bleeding. And I said, that kind of makes sense. So what we started doing at WashU, we do not do at Hopkins yet, but I'm working with our pheresis team, is instead of the IVIGG after each pheresis, we gave fresh frozen plasma. So one, the cost of that is about $100 versus several $1,000s for the IVIGG. So it's something to think about. An argument against that, they will say, wouldn't the IgG have, or the fresh frozen potentially have DSA? Well, maybe, but we haven't seen a problem with that. So it's just something to think about when you're trying to make things more cost effective.
Dr. Brennan, we always
Dr.
give fresh frozen plasma with the plasma pheresis. This IVIG is in addition to fresh frozen plasma. So that is part and parcel of the plasma pheresis treatment.
And maybe that's why it works well. If it works well for you, maybe why? Because, Stan Jordan is all about, it's the IVIG that matters. So, but in the United States, we can't get his protocol to work because we don't do it. He wants to give 2 grams per kilogram of IVIGG, which is huge.
So at this stage, let me bring in Dr. Shishir. And Dr. Abhi, I will want to know about the kind of levels you have in mind for these high-risk patients. But before that, Shishir, if the patient has not been lucky and has developed acute rejection, what are your recommendations, or rather the standard treatment which you use for a T-cell mediated acute rejection?
The T cell, fortunately, the numbers have really gone down, but they still do occur. And what we do is, if it is like 1A, then we would give corticosteroids, that is methylprednisolone 1 gram daily for 3 days, and then use a milligram per kg and taper off over a period. Most of them would respond within 5 to 7 days. The creatinine will come down within 10% of the baseline creatinine. However, what we have seen in the recent last almost about a decade, since the introduction of tacrolimus, that the rejections that even T cell that they do occur, they are more resistant to steroids than they were in the past. So nowadays, our trigger to use ATG is much lower than what is in the past, though the histology is important. At 1B or more, of course, straightaway we'll use ATG. But even for 1A, if we find that the creatinines are not dropping the way they should be within the 4th day or the 5th day, we would then introduce ATG. Our usual dosing is 1.5 milligram. We give it daily. Unlike what we use for prevention, important for rejection is to use a little larger and longer dose, because we want to kill the cells which are there in the graft. So we use 1.5 milligram per kg daily, and we try to use about 5 milligram per kg total to 8 milligram per kg. Of course, these patients would then eventually go on to a little higher dose of tacrolimus if they were on a lower dose, optimize a dose of MMF. Steroids will not taper as fast as you would have done otherwise. And also at this point, we would use, if you're not used prophylaxis for CMV, and I believe in our country, most of them would be on a cotrimoxazole prophylaxis. So this would be our strategy to manage. Rebiopsies, we are generally not doing it frequently, but if they do not respond within the week, then we would do a rebiopsy and see if what's the reason why they are not responded, whether to step up or consider something else.
Dr. Brennan, this one is for you. What is the role of rabbit ATG in the treatment of antibody-mediated rejection? You remember we recently discussed a case where you had recommended that, yes, it's a mixed rejection, predominantly, it was rather a mixed one, and you recommended, let's try ATG. So would you recommend the routine use of ATG in ABMR?
Sure, and let me comment about Dr. Gang's approach. I agree with that completely. There might be a role for donor-derived cell-free DNA to look at how the kidney is responding. So if you see that it's dropping. One thing about the cell-free DNA, we recently published that the very act of putting a needle into a kidney raises the cell-free DNA. It goes back immediately. It goes back to baseline within about 24 hours, just so you need that. So with antibody-mediated rejection, as I've told you, to be completely honest, I don't know what it is anymore. How they describe it. And I know that T cells are important for B cells. So it seems to me a little bit of thymoglobulin is good for antibody-mediated rejection. Part of the problem with it is the timing. And I used to alternate thymophoresis. And then I think my nurse practitioner said to me, are you an idiot? You're just removing the thymo you just gave with each phoresis. So then I decided, usually what happens is it's a Friday, you do the biopsy, I look at the biopsy, I don't have the DSA back, I give the thymo, find out it's mostly an antibody-mediated rejection. So then I'd give the thymo at the end, rather than giving, say, rituximab, because I think the rituximab has been, I don't think it's added much, to be honest. That's what I'm trying to do now.
So, Dr. Ravi, back to you. Of course, about the levels you have in mind, but at the same time, what are the predictors of outcomes in antibody-mediated rejection? So, over to you, Dr. Ravi.
Yeah, I think the ones who have severe glomerulitis, more PTCitis, and the ones who have maybe associated TMA, thrombotic microangiopathy, which often or can occur as a complication of AMR, severe renal failure, like the ones requiring dialysis. I would say these are the people who require more aggressive form of treatment. But ABMR in the first few months, like first 6 months, often reversible, often do respond to treatment, and then most of them attain normal renal functions can remain rejection free for several years. And these patients actually we try and maintain a higher TAC level, maybe around 8 to 10 nanogram, and then we don't reduce the dose of steroids as the way we should be doing for other patients. And as Shishir pointed out, they will be on Valsite and then Tocotri prophylaxis also.
Quite agree with you there. Is Dr. Vivek Pathak? I think he had some emergency to attend to and probably may not have been able to make it. If he's not there, this one is for you, Shishir. You talked about the fact that T-cell mediated rejection, pure one, is not very common these days, but we do get to see a lot of mixed rejections. So how do you go about treating the mixed rejections or the steroid-resistant rejections? Dr. Brennan did allude to the fact that even steroid-resistant in cases, you can try steroids, higher dose and more frequently. So how do you treat mixed rejections?
Most what you notice is a mixed rejection occurs a little later, and they don't come in early. They are often associated with reduction in immunosuppression, either physician-induced or by the patient. And they are really hardy to treat in the sense that by the time they come in, they have a very mixed picture. And when you see the biopsy, they are often have already features of chronicity. So in them, unfortunately, we have not been very successful in treating that. But what we try to do is that because patient's creatinine has gone up, we need to do something. We would do a plasmapheresis. And as Dr. Brennan said, I do use ATG, thinking that it is like a little bit of a carpet bombing. So maybe a lot of whatever cells have come in, and we might be able to reduce those. And of course, we would reintroduce if any changes have been made in the baseline immunosuppression, MMF as well as tacrolimus, and ask if they're not be able to tolerate it, what are the reasons of non-tolerance or non-adherence, and then accordingly treat it. We have not been successful. We tried using bortezomib in the early phase, in the beginning, but somehow it didn't really work. I mean, we gave the doses, 4 doses, everything, the protocol that is described, but it didn't really work for us. So bortezomib, we couldn't. Of course, the other drugs are not really available. Rituximab, we have had a mixed feeling. We sometimes have used it, but we couldn't really point out whether it worked or did not work. And so I'm really, honestly speaking, not able to give a clear answer, but we try plasmapheresis, give thymoglobulin. Some patients we give rituximab. Bortezomib we have stopped using now.
That certainly helps because it's I think very difficult task ahead of us. So in the paucity of time, two last minute questions. Over to you, Dan. You wanted to end on a promising note, and you told us about many experimental therapies. Which one are you in particular looking forward to? Is it Berinet? What is the role of C1 esterase inhibitors or some other therapy which you are yourself eagerly looking forward to having?
So I was part of a grant with Flavio Vincenti and Stuart Kneckley and a bunch of people that received a horrible score from the NIH, so it's not going to go forward. But I was excited about the animal work that Stuart Kneckley had done down at Duke. And it involved the anti-CD38 antibody. It had involved the combination of that with the anti-CD40 and 40 ligand, seeing now that they put that on the back shelf. Again, this anti-CD40, 40 ligand business has had a problem, historically. So I like the stuff with the anti-CD38. And then the newest thing, getting back to the lecture just before mine, using CAR T cells. But the problem is I'm thinking of using the CAR T-like cells for treatment of BK CMV, as you heard about in the lecture before mine. But I'm getting pushback from our IRB because the real people have used the CAR T cells and stem cell transplant. Turns out there's a lot of side effects and a lot of cytokine release. Interestingly, they're using tocilizumab, so the IL-6, the anti-IL-6, to control all those. And so maybe there's going to be a combination of the anti-IL-6 and the CD38. And CAR T. Those are, I don't know. That's what I'm thinking.
Great. And do you think addition of donor-specific antibodies to donor-derived cell-free DNA would help add to the value and make things easier for us? The combination, or would you want to go in for just? So
you're breaking up, but I think that it's a word, but that since you can just the
Brennan, the
sort
voice was
harmful from non-harmful DSA, harmful from not. I think DSA.
Okay, so I believe Dr. Pathak has joined us. If Dr. Vivek Pathak, if you're there, we would like to know from you when would you rather use a thymoglobulin or rabbit ATG in the T cell mediated rejection? When do you really bring in? Is Dr. Pathak there? I just thought he was.
No,
if
sir,
not, then
right.
He's not there. Okay. So the last question again to you, Dr. Brennan. How about
time?
Okay, just a last question to Dr. Brennan, and that's the role of subclinical rejections. So what do you think should be done? Because so many times, by the time we pick up, it's too late.
I think that the donor-derived cell-free DNA might be useful to sort out harmful from non-harmful subclinical rejection. And only I do is again doesn't do much and cause more infection. That's what I would do.
Well, thank you so much. I have got a signal from the organizers. I mean, this discussion can go on, and I, on behalf of my fellow nephrologists and transplant physicians and surgeons from the country, wholeheartedly extend our gratitude to you, Dr. Brennan, as always. I mean, you have been a big help to the community here, and we always look forward to having you actually for any of our meetings. And let's hope that the normal days prevail one more time, and we are going to have you again here with us in our country. So back to the organizer. Thank you so much, and all the more because it's been too early, and it's been cruel to you this morning, asking you to wake up so early for us. Thank you so much indeed. Back to you, the organizer. Thank you so much for this wonderful opportunity. On behalf of my fellow panelists, both Dr. Shishir Gang and the organizing chairman, Dr. Abraham. Thank you so much. Bye-bye.
Bye.
Thank you, Dr. Brennan and Dr. Shishir and Dr. Kulnar.
Thank you. Special thanks to the speaker, moderators, and the panelists for this wonderful session.